Hi Pediatric Squad. Today we talk about congenital hypothyroidism. So if you can spot that, if you start thyroxine, you can actually change your life. So this is very important. You can change your life if you can spot that, and it's very easy to treat. So why I said this is very important, because it is the most preventable cause of cognitive impairment. If you can pick it up, if you can treat it, you can actually save a child from having cognitive impairment, which is very important. What is congenital hypothyroidism? So let's break it down. First of all, congenital means present at birth, right? Hypothyroidism is easy. It means not enough thyroid hormone. Why is it important? First of all, if they are untreated, they can have intellectual impairment. Their brain can have damage. They can have developmental delay. And secondly, they can have growth failure. They can have short stature if you miss it or if you don't treat it. So take a look at this baby, take a reference from some journals. Generally, the baby can have like gross face, umbilical hernia. They can have a large tongue or macroglossia. When you palpate the anterior fontanelle, they generally can be large. And also they can have constipation, prolonged jaundice, and more importantly, they can have the sensorineural hearing loss. So it's quite important, but still, the most important thing will be if you treat it, you can prevent them to have the intellectual disability and prevent them to have the growth failure. What is happening? Why those child are having congenital hypothyroidism? What are the pathophysiology? Before that, I would like to ask you to subscribe this channel, because I would like to build up a community for pediatricians or actually any others who work in pediatrics. I have opened a Discord channel to share some latest journal to you. We can ask those silly questions that you don't want to ask your senior there. So do join the Discord. I will give you the link in the description box. Get back to the topic. What happened to hypothyroidism? So let's imagine all of us needs the thyroid hormone, okay? And the thyroid hormones are actually called thyroxine, or the inactive form is T4, okay? So let's imagine the thyroxine is a bracelet. And imagine our thyroid gland, the place to produce the thyroxine, is the factory. Okay, so when you have a factory, you make the bracelet. First of all, you need to have the order, right? Some customer have the order, or your boss asks you to do it. So the order is delivered from the pituitary gland, which is an organ in our brain to produce many different kind of stimulating hormone to ask our body to produce the hormone. Okay, so the pituitary gland in the brain will give out the order to the thyroid gland, our factory for producing the thyroxine. Okay, so how do they give the order? They give through the TSH. TSH, the full name is the thyroid stimulating hormone. So they release the TSH to ask the thyroid gland, the factory, to produce the thyroxine. So before that, actually before the pituitary gland, our brain has a higher structure, which is called hypothalamus, which is the part of the brain to control our body temperature, to control different kind of hormone. So they release a hormone called TRH to pituitary gland, and the pituitary gland will release the TSH, the order to the thyroid gland, and ask them to produce the thyroxine. Okay, so this is the diagram show you. The pituitary gland produce the TSH. Okay, so when the thyroid gland receives the order, they reproduce the thyroxine. So our thyroid gland reproduce the thyroxine, the T4. As I said, this is an inactive form. So the T4 will be converted to T3 in the peripheral tissue. T3 is the active form to really shows the effect of the thyroid hormone. All right. So what is happening in our thyroid gland is really like a factory. Let's use back the metaphor of the bracelet. Okay, so in order to build a bracelet, first of all, you need to have the raw materials, the beads, right? So iodine are the beads. They are the raw materials. They are consumed in our diet. So inside the thyroid gland, inside the factory, we also have something called thyroglobulin. You can imagine it is the string for making the bracelet. And we have an enzyme called thyroid peroxidase. You can imagine it is the hand of the factory worker. So the thyroid peroxidase will try to make the bracelet by using the iodine and also the thyroglobulin. And then we will have to find the product of the thyroxine, the bracelet. Okay, so if we lose one of these things, we can't produce the thyroxine, and the baby will have the congenital hypothyroidism. So let's talk about the causes of congenital hypothyroidism. So first of all, the commonest cause will be the thyroid dysgenesis, which is account for 85% of cases. So either you do not have the thyroid gland at all, you don't have the factory, which is called thyroid agenesis, or is underdeveloped, which is called thyroid hypoplasia, or is in somewhere else. It's not in the designated places, which is called atopy of the thyroid gland. But most of the time, these thyroid gland in the abnormal place are not functioning well. Okay, so this is the most common one, the atopy. So most of these causes are sporadic, which means the patient may not have the family history. They are just born like that. All right. And the second common cause is the dyshormonogenesis, which accounts for around 15% of cases. What does it mean? As I said, inside the thyroid gland, inside the factory, you need to have these things: the iodine, thyroglobulin, and the thyroperoxidase. So this homogenesis means either one of these have some problem, so that the thyroid gland does not function well, so that no thyroxine is being made. All right. These kind of causes are usually due to some genetic causes, usually inherited in like autosomal recessive pattern. They may have some goiter because the thyroid gland is there, just that it doesn't work well. Okay. So therefore, when the pituitary gland keep giving the orders by the TSH, keep giving that, and the factory cannot function well, so that they need to get bigger and get bigger in order to produce the inner thyroid hormone. Therefore, the patient may have goiter. And the third cause is central hypothyroidism, which means the pituitary gland have some problem. They cannot give the TSH, they cannot give the order, so that the thyroxine is not enough. And usually this is associated with some like midline defect. The patient may have also other hormone access problem. So there are also some causes which just lead to transient congenital hypothyroidism. Because for the cause that I've just mentioned, most of the time the patient may have lifelong congenital hypothyroidism, unless we replace it by medication. But there are some causes which lead to transient congenital hypothyroidism. For example, iodine deficiency. In some country, people can have iodine deficiency, and for some other, they can have some exposure of high dose iodine to the fetus or the newborn. For example, if the mother took the medication like amiodarone, or they receive some radio contrast, sometimes the baby can have the transient hypothyroidism. Or if the mother have some antibody, for example, TSH receptor blocking antibodies, they can transfer to the baby and make the baby have a transient hypothyroidism. Usually for transient cases, it will resolve in the first few months or first few years of life. Then, having said that, it's such an important topic, we must pick it up. How do we diagnose this problem? How can I save a child from intellectual impairment? Actually, in many countries, they have adopted newborn screening for congenital hypothyroidism, which means for every baby given birth in their countries, they will screen all babies for this condition because this is very treatable and it can lead to severe consequence. And how do they screen it? Most of the time, they do a heel prick, which means put a small needle and then on the soles of the baby, and then they take out some blood and check it in a filter paper. So most of the time, they will test either the thyroxine level, the T4 level, to see whether it's low. If it's low, then it has problem. They need further workup or even treatment. Okay. Or on the other hand, they may check the TSH, because for most of the cases, if the factory have the problem, that the thyroid gland have the problem, they cannot produce the thyroxine. So your pituitary gland will give out more order, because the body can sense that, oh, you don't have enough thyroxine, I must ask the thyroid gland to do more. Therefore, TSH will raise. And therefore, in some countries, they will go for the approach of checking the TSH first. If it's high, then it has problem. If in the screening test, either the T4 is low or the TSH is high, they need to go for confirmatory test by taking the blood for a formal thyroid function test. Okay, so this is the flow chart that most of the time we follow. Of course, different countries will have different approach, but then the general idea is like this. So first of all, if you do the T4 first, for example, if the T4 is low, okay, they will try to test the TSH. If the TSH is not elevated, sometimes most of the time they are the normal infants. All right. However, if the TSH is also elevated with low T4, then the patient will need to go for the confirmatory test. Because I just said they use a filter paper in the beginning. But if you want to do the confirmatory test, you need to take the blood again to save the baby's blood inside a bottle, okay, and go for the laboratory test, okay. So if the classical picture happens, you will have the high TSH because the pituitary gland keep asking the thyroid gland to do something, and you have a low thyroid hormone, low T4. Okay, and you can confirm it is a primary hypothyroidism. So you will need to treat the patient with thyroxine and also need to do some further workup. And I will talk about it later. Or if the patient rarely has the central hypothyroidism, which means the pituitary gland problem, they will have both low TSH and low free T4. And for some cases, they may have normal TSH. But then it can confirm it's a central hypothyroidism. Again, you need to treat it. You need to treat with the thyroxine. All right. Of course, you can also test the TSH first. For if it's elevated, again, you go for the confirmatory test and then go to the flow chart. That's like what I said. So if you confirm the patient has a primary hypothyroidism, you need to treat them with the thyroxine and also do some further tests. What are the further tests? As I said, the most common causes will be the thyroid gland is not here or in some abnormal places or they're under development. So you can actually book an ultrasound thyroid to try to find the thyroid gland. And there is also radionuclide uptake scan because if it can shows up the thyroid gland. For example, if the patient have atopy of the thyroid gland is in an abnormal place, this can tell you where is it. And also, you can check the thyroid autoantibodies in mother and also baby because this can lead to transient hypothyroidism. You can also check the baby's urine iodine to see whether the iodine level is in excess or deficiency. So what are the treatment? Levothyroxine, 10 to 15 microgram per kilo per day. All right. You need to treat the patient early once you make the diagnosis because timely management is important. If it's too late, the hypothyroidism may already damage the brain development. The goal of the treatment is easy. We want to make sure the free T4 level is normal, especially we want them to at the upper half of the reference range. And we want to make sure the TSH is normal and prefer a lower end of the reference range. So both of these are normal, okay? And eventually we want the patient to have normal growth and development so that you need to check this during the follow-up to monitor the growth and the development. And how long to treat? Sad news is for the permanent congenital hypothyroidism, you need lifelong treatment. Who are they? For example, those with thyroid dysgenesis, you don't have the thyroid gland at all, or abnormal thyroid gland. Those with dysharmonogenesis, the factory problem, and most infants with central hypothyroidism, those with pituitary gland problem. You will need lifelong treatment. But good news is, if you treat it, the outcome is good, but you need lifelong treatment. For those with transient congenital hypothyroidism, for example, if the mother have autoimmune thyroid disease or excessive iodine exposure, usually no need lifelong. They may need the treatment, for example, a few years. So what are the prognosis? If you treat early enough at 2 to 6 weeks of life, the development and growth outcome are very good. Okay. But if not well treated, 10% of them may have the hearing impairment. And therefore, most countries are having the screening program because sometimes the patient do not have symptoms at all in the beginning. So if you screen it early, then you can save their development, save their growth. Okay, so these are the key takeaways from this presentation. First of all, congenital thyroidism is the leading reversible cause of neurodevelopmental impairment. Newborn screening is very useful, easy to treat. We just treat with the levothyroxine, and some of them may need the lifelong treatment. So it's very important. I believe that this video is just a start. I always think AI, this kind of YouTube video can replace your own readings. So do check out the reference in the description box. And again, I hope you can subscribe this channel because to join our community for the pediatrician, not only the pediatrician, but also the pediatrics related health stuff, and then join our Discord channel to have some discussion, to have some interaction. I really hope that we can build a community for pediatrics and to help our children more. So do check out the description box. And I'll see you next time. Okay, bye.